Welcome everybody. I'm Jaspal Singh. I'm a pulmonologist in Charlotte, North Carolina. And with me today, I have a very esteemed group today, Dr. Ashutosh or Ash Sachdeva, Dr. Laura Fry, and Professor Suvir Singh. Dr. Singh actually comes from London, UK, so he's joining us at 1 a.m. in the morning, and the rest of us are either on East Coast or I think Mountain Time, I believe. And so, but we'll hopefully have some fun tonight talking about elevating bronchoscopy training. And we hope for a really interactive session, talking about the global perspective on current practices and future needs from critical care to the bronchoscopy suite, and special thanks to TSC LIFE for helping us. So with that, let's get started. So just to give level set a little bit, we're going to talk a little bit about some introductions. Obviously, we're going to introduce our speakers. I'll probably have them introduce themselves as they come and give their little segment, because that'll be a little bit easier. Needless to say, they're all experts. And look about bronchoscopy training. So how are we training people in to be competent, proficient in bronchoscopy today? And can we maybe start thinking about some common challenges and look at some modern educational modalities? Like, should we change how we train people? And just thinking about different learning environments, looking at what technologies are out there, and looking at emerging tools. And we'll talk a little bit about some of them actually, and then hopefully have some time for a discussion about where is this going, or maybe where it's not going, or where it should be going, and what do we take home from this? So let's look at some educational modalities. So evolving educational modalities, they're continuously evolving. There's a lot of interest in educational technologies like hands-on practice, a lot of better understanding of engagement and retention. Back then when I trained bronchoscopy, things have evolved tremendously in this space. So, but there's also some challenges actually. As bronchoscopy, for example, is rapidly expanding in expertise and what it can offer. There's a lot of demand for the expertise and a lot of new ways to get trained. And some are offered by institutions, some by industry and others. And the training environments change dramatically. A program in one location can look very different than another location. And there's also sort of additional challenges in adult learning logistics. For example, some of the technologies that I learned in my training wasn't even around or even close to being developed. And now how do I, as an adult learner, continue to advance my understanding, and same with others? And then there's the idea of retention and just-in-time learning. Just because you learn something one day by 1 year attending a seminar, is that going to be retained? And how do we kind of augment that learning to be just in time? And then, of course, how do we get faculty training, resource needs, and the things that we need to do this well? So just to frame that, there are some paradigms out there like high fidelity simulation, which has really advanced a whole lot now in terms of realistic training environments, replicated patient anatomy, and really just enhances the overall experience for a novice, especially. But there's some pros and cons here. It works out great in some ways, but it doesn't always work out. There's a lot of challenges with that. In our institution, it's very hard to get time in the simulator with an experienced faculty member, and there's a lot of other challenges in terms of getting a good experience. So how do we do this, and how do we do this well and pragmatically? And then animal models. Some people teach a lot in animal models, and today's faculty actually have a lot of experience in all of this, actually. They're great for certain invasive procedures, but is it really the same? And so there's pros and cons about animal models. For example, the cleanliness, the hygiene, any disease transmission, ethical concerns, and anatomy issues. So there's a lot of pros and cons here of how do we train in bronchoscopy, because I learned some of my things on animal models, and I'm not sure how much that was worth it for the amount of time that we invested. And then 3D printed models. For example, now we have all these interesting materials and ways to print things that are very interesting from a tactile learning perspective and can be customized. And you can do all kinds of procedural training with some of these now. But there's pros and cons here. Is this cost efficiency? Does it really work? Is it really the same thing? And these are things that we're all kind of, as educators, thinking through a little bit. How does this work today? And then, of course, there's augmented and extended reality. This technology has really evolved. If you're a gamer, if you're someone who understands this stuff and enjoys this aspect, it's amazing how realistic some of this can become and where this is all going. And in bronchoscopy, there are some applications now. But there's also some pros and cons, understanding this technology, using it well, having faculty that will train well, the investment requirements. And then there's other factors, of course, the logistics and such. And of course, virtual reality is the next level of that, and we can talk all about that. There's also some ideas of things like gamesmanship to kind of improve interactive learning, and it can be quite helpful. But again, now you've added competition, and now you've added a whole bunch of logistics, and for people who are already stressed, now you've added more stress to them. So these are just some of the things we're going to talk about. And I'm super excited about today's faculty, because they're going to touch on some of the ideas of diverse training methods, some of the pros and cons of these aspects, what skill acquisition looks like today, and where it's going. And we have so much more to learn. So without further ado, Dr. Savir Singh, I'd like to sort of turn it over to you.
Thank you so much, Jaspal. That's a fantastic intro. So I'm pulmonary and critical care. I divide my time. Next slide, please, Jaspal. Thank you. And I'm going to just look at, take it back a step to the process of early learning, right? We all have forgotten about how we learned at the early stages. And one of the questions really is, can mixed reality make bronchoscopy better, safer, and particularly in this respect, accessible to the many? Next slide, please. You know, we can go back to thinking about how we develop, right? Miller's triad tells us that we go from knowing how, to showing and doing, you know, transitioning from cognition to behavior. And so that's, for me, that's unconscious incompetence. You know, you don't know that you're rubbish, to someone telling you that you're not so good, and then you go through the training path, and then the driving the car, right? You don't have to think about it. But sometimes you learn something new and you have to step back to that conscious competence. And the guy here in the bottom right, the great Halstead, who was at Johns Hopkins during the time of William Osler, and he was the one who residency programs came from, and the see one, do one, teach one is ascribed to him. And I think it was about progress through proficiency and assessment at each stage, and that's really what his. But that's very labor intensive. So next slide. So are there ways that we can actually make it meaningful at the early stages of learning? Now you might say, you know, bronchoscopy in the ICU is just putting the snake down the tube and sucking. It's probably more than that, right? And there are a number of different reasons why one might do a bronchoscopy in a critically ill patient. Next slide, please. So it's perhaps more than that. And the question is, and of course, this is an example of where you really need to know what to do and be trained well. Emergency airway hemorrhage protocols. That needs to be done well, and it needs to be understood, and you need to be able to reproduce it. So when that occasion does arise, you rise to the occasion as opposed to fall to your level of training. So next slide, please. And within that, you know, now with the advent and the expansion, mass expansion of single-use disposable bronchoscopy and a whole range of industry partners who are coming into this, it provides a real opportunity, particularly as the optics are really improving now, and dexterity skills and transferability of images allow for wider learning. Next slide, please. And this is perhaps a really great example from CHEST 2 years ago, the expansion and the exponential rise of bronchoscopy in the ICU setting. But really importantly, how there was such a large variation in reported practice compared to other ICU procedures. Next slide, please. And that was, you know, more than 500,000 patient bronchoscopies, and you can keep clicking on that. And really the question is here, why is bronchoscopy treated differently to other ICU-based procedures in training? So if you keep clicking on that, Jaspal, you'll see that, you know, the airway, of course, is top dog in the ICU setting. And then, of course, we've got vascular lines and echo and ultrasound, but you know, bronchoscopy is still the Cinderella of ICU, and the question is why? And it's partly because we don't really know how it's done, who it's done by, where it's done, and for what reason. So we need more data on that. Next slide, please. And we've just been doing some work in the UK, and essentially, whilst we know that 50 to 70 in the early stages is important, actually before that level, satisfaction with training is very much linked with confidence levels. And we know that once you get to that plateau, then you can start to be thinking about proficiency testing. And what are the big things for the ICU clinicians? They want to know about anatomy, of course. They want to know about navigation. They want to know about dexterity and handling. So those are the big answers that are coming out of what people want. Next slide, please. And of course, we've got some pretty good validated tools like the self-assessment tools, the self-directed reflection, the BSAT, and then of course then there's the formative assessment tool, the BSTAT. So these things can be used. The question is, are they being used, and could they be incorporated more effectively? Next slide, please. And some of the work we've been doing, so there's, as Jaspal was saying, many different ways that you can learn, right? You can get your Pulmex on your smartphone. You can use your ORSIM, a VR, a Symbionics big version, or you can use your Koken model with the haptic control, or a biosimulated model. And they all have slightly different aspects of feedback, realism, haptics. Next slide, please. And next, please. Yeah, that's just an example of the Pulmex. So the question here is, as you are learning, what if you had a sat nav down the bronchial tree? Would it help things? And we've been working on a device. Next slide, please. From the Ambu company, and this is just an example. It's currently in a prototype model. And essentially what it shows you is that you can tap on it onto training mode, and then there's a testing mode as well. And it gives you on-screen labels. It gives you a lung diagram. There you can see the lung diagram in the bottom right. And actually it tells you where you are and what the segmental anatomy is as you enter it. It not only tells you how many segments you've gone into, it gives you a score. It also tells you what sequence you've gone in. And that's important, right? Because we know that structured progress and ordered sequence increases the chances of you getting a complete navigation. So that's pretty good, and we've looked at this, and of course it uses the NACA scheme and the numbering. We don't know what the code is. It's a proprietary code, and it's supervised learning, but it hasn't been trained on ICU patients yet. So that's the next stage. Next slide, please. And we can keep clicking through this. We've done a few studies now over the last year or so. We've shown that system is better than, so novices perform better when using this device compared to self-directed learning. We've shown that it can automatically assess bronchoscopy performance compared to experts. So you could train on it and you could be assessed on it on its own. When we looked at pulmonologists, we found everyone of different experiences from low to high improved their performance in this simulated setting by using this. And even in mastery learning, there was a slight increase. We just published in CHEST, in critical care medicine, that training on this compared to an expert training you, you did better. And that's probably because it was task focused rather than, you know, the so-called experts just telling you about how you could stand a little better or move a little better. So there could be some interesting ideas. Next slide, please. When it's compared against the virtual reality ORSIM, it stands up pretty well. And in terms of cognitive load, in the top right there, actually it seemed to be there was a lower cognitive burden by training and testing on this device compared to the experts. And that must say something around not having someone breathing down your back while you're learning. So there are some interesting ideas here. Next slide, please. And as we move on, we've got a qualitative study that's again looking pretty favorably with the idea of training and potentially using these devices in a clinical setting to aid with that early learning of bronchoscopy navigation and anatomical location. Next slide, please. So as we as we sort of conclude, I just wanted to say that what we've been trying to look at is a very specific aspect of training in the early stages, more specifically in the ICU setting. But it seems that the mixed reality, together with those other formative assessments, could play an important role. So thank you for that.
Very nice talk, Suvir, and I learned a couple of phrases, the British phrases. Haven't heard the word rubbish for a long time, and in US we say breathing down my neck. But I think, Jaspal, you did a wonderful start. All the questions that you asked, should we teach differently? I think the short answer is yes. Should we have a different learning environment? I think the generation is changing. So again, the short answer is yes. My name is Ash Sachdeva, or Ashutosh Sachdeva. I'm at University of Maryland. I've been teaching bronchoscopy, and I'm passionate about simulation-based learning, including cadaver models at University of Maryland. So I will take you can advance the slide. I think one of the things that has been mentioned is about volumes. How many procedures does somebody need to be competent, become proficient, and then have a mastery? I think in general, the experts are able to deconstruct the procedure, and more we have moved away from volume-based to competency-based. So the competency-based as defined, and you can click on the slide to highlight what I want to intend to say there, it is basically driven by, do you have a grasp of the procedure in all respects, from indications, contraindications, risk, management of complications, then can you do the procedure in fluid motion? Most importantly, the way we look at competency is, can I trust you to be my physician? And I think fundamentally, when you can answer that question, you have achieved competency, and eventually through that, you can achieve mastery. You can move on to the next slide. I think the animation, yeah, thank you. So this is a graph talking about learning curve of different pulmonary fellows, and it clearly tells you that everybody is different. They probably have arrested development at certain stage, and until a light bulb lights up through either coaching, repetitive tasking, deliberate practice, they are not in general able to move forward. And that's why you see up and down in terms of how they progress. But they all eventually progress after a certain volume. Again, highlighting that volume is important, but can we truncate this to the next level without having, especially for the high risk, low volume cases that are important in ICU practice. So I'll share some of the attributes of learning. You can keep progress. And this is one of the articles we wrote about motivation and learning. This was an editorial for the article that Suvir shared. This was a study where AI feedback was important. One of the most important things that came back from the study was that when the AI was giving feedback, and as Suvir rightly said, the expert was not breathing down your back or neck, you actually had greater motivation in learning, and you were excited through gaming mechanism on how I could improve myself. And as you improved yourself, you were spending more time with the device, and that is what is important. Ultimately, is the time and deliberate practice of the actions. You can keep moving, Jaspal. Yeah. If the slide is stuck, and most important thing about any learning is positive reinforcement. I can't tell you how many times I see adult learners getting stuck on just tightening the gas cylinder, right? So when I say open the gas cylinder, we almost invariably do the other motion. So this is how I taught my team righty-tighty, lefty-loosey with a big cake. They thought that I was snarky and sarcastic, but the point being, in a lighter tone, that positive reinforcement helps. Next slide. I think it's going to jump again. The other most important component of teaching a skill is, how do you deconstruct the procedure? This is a very simple broken down task when you have an endotracheal tube adapter and you're holding the scope. a lot of novice learners will hold the scope with 3 fingers to give greater stability, forgetting that that becomes a impediment in driving the scope. So here we are actually taking a picture and showing the learners how to use your fingers to stabilize the endotracheal tube, and then with ease drive the scope up and down. Likewise, we work with the learners on driving the scope to the right mainstem and the left mainstem. You can keep going if it's working. Yes. The purpose of this is to help them understand that the airway is not a straight cylinder. So as you'll see in the next slide in the animation, as the learner drives down the low fidelity model in a tortuous airway, the cylinder has one axis, but as they drive down, this is actually a cadaveric model, the axis changes with each cylinder being a tracheal ring here. And as the axis changes, the learner has to adjust their handlebar motion to the of the scope. As it goes into the next phase, we now have the learner struggling how to drive the scope past the cords when they're driving down the mouth. So in the next animation, I demonstrate how you can deconstruct these steps to help them understand the geometric axis as well as the handlebar motion. In this example, we have a trachea, which is tortuous. That's a sagittal view. And if you see, the scope is sitting at the cords, and this is the view a learner would have. As we advance the slide, you'll see that, or advance the animation. So you're looking at the cords, but that means the scope is flexed. And as you advance the scope across the cords, you have to make a motion. Otherwise, it's going to hit the anterior wall of the trachea if you don't adjust your handlebar or do a retroflexion. If that doesn't happen, the most intuitive thing that happens as they pass the cord is they get energized and they hit the anterior tracheal wall, and then the patient has coughing. And the natural reflex to that coughing is that you will withdraw the scope and invariably you'll come out of the cords. That means the process will repeat itself and the patients will need higher level of sedation. Now, if the learner has gone through what Jasper was saying, just-in-time training, or we have reconnected the learner with this concept, it becomes easier for them in an actual patient, and then they can drive the scope with greater ease. So if Jasper, the animation works, which is, it should, I think it's slowing down, is just to demonstrate that there is the next phase in learners' indecisiveness is where should they go. I guess most of the experts have seen, should we go to the right or the left? And I say, whichever seems easier for now, just go to that side, don't worry. And I think the animation repeats itself to hone down the concept that if you are at the vocal cords and you're seeing your scope is generally flexed when you're looking at the cords, as you pass the cords, the greatest diameter, you have to do a thumbs up motion or a retroflexion to stay away from the obstruction. And in this setting, you also have a slight tracheal stenosis at the right lateral border, and then you have to make a leftward rotation to go away from it and not hit on it. The more you touch the airways, the greater the patient will have the desire to cough you out, even if they are sedated, unless they are paralyzed. What is more important, it is commonly assumed, yeah, you can keep going to the next slide, Jasper. It is commonly assumed that you need a big-time proctor, faculty attending. I think it is demonstrated by this group from Alan Tremblay in Calgary that you could have respiratory therapists be the proctor. They could be the assessors. And sometimes the learners are at much more ease in spending time with individuals who are not judging them directly on their skills. So they are part of the team that can actually evaluate you. And this is the model we have adopted at our institution. Our respiratory therapists and bronch suite nurses do the BStat evaluation that Suvir was showing. And I don't have to worry about it because I have trained our team to how to best assess, and there's consistency across the assessment as well. Now, this group actually went further to look at the primary outcome of procedure time and a percentage of the time the lymph node were identified by the staff. And the learning curves are very similar. An important concept, again, is the deliberate practice. It's not just how many hours you are spending, and you can see what the students are doing in a typical week with regards to leisure time and number of hours. If you're doing deliberate practice, the best students have the ability to optimize their time, and they can actually squeeze time out of the total duration. Go to the next slide. And this is where the meat or the holy grail in deliberate practice is. You have to spend almost 10 years or 10,000 hours, again, with a mindset that you are going to not just get arrested in your development, but you're going to look at and do a SBAR type of assessment, get feedback from expert or some type of technology, and then go back on the areas that you lacked, just like you practicing for a test. You pick up the areas that you're not performing well, and then you go back and study that material. Here you're practicing that. So if you can incorporate that in your daily practice, and whether you use low fidelity model, high fidelity model, animal model, I say that the model that you're going to use to practice is probably the best model. If you can buy a $100,000 machine, but if you're not going to use it, it's a waste. You can buy 10 low fidelity models sitting around your bronch suite. If you're not going to practice, it's a waste. So that's critical to understanding for the learners. Next slide, please. We have successfully done cadaver labs, and I'll tell you, the enthusiasm of the proctors is infectious. So here I have Carla and Colin. The reason I put their pictures is, and you may not be able to appreciate, they both are sweating from top to bottom. They were standing in the cadaver lab where it's hot and humid, and they were there for almost 7 hours teaching straight without a break. And at the end, they didn't complain, but they said, next time, can you just put us for a 4-hour block, not 8 hours block in the cadaver lab? And you have to create a risk-averse environment where the learners can do mistake and go back to the deconstructed steps and repeat those steps. What we learned is that if I give 90 minutes on a cadaver versus 45 minutes, the learners actually appreciate 90 minutes of interaction rather than a 45 minutes where they do the task, but maybe they are feeling rush. And this is my final slide on what it actually means in terms of competency and a mentor-mentee relationship. The person who is blindfolded is the only person I have trained in the last decade whom I put a blindfold on, because I felt that after a month, this individual had all the skills. He challenged me, and I said, no, you have to trust yourself, and I trust you. We put the blindfolds, and I only gave him auditory feedback on driving the bronchoscope in an intubated patient. And he drove to all the segments, and we, in probably less than 3 minutes, we made sure we are not creating an unsafe environment for the patient. The point being, I think when the learner is trained, they can start imagining things. They know haptic feedback. They trust their drive of the scope, and so forth and so forth. He's one of the finest cardiothoracic surgeon who's practicing at University of Maryland now. He was a resident in thoracic surgery at the time. I looked much younger at that time. So, and I want to thank TSC and as well as SAB for the opportunity to engage with such a wonderful group of faculty and learners over here. Thank you again.
Thanks, Dr. Sachdeva. Thank previously, Dr. Singh. You guys are knocking this out of the park. This is a lot of information condensed into a short amount of time, and I'm sure Dr. Fry will not disappoint either. A lot of information in a very short cycle. So let's kind of keep that streak going. All right.
Perfect. Thank you, Jaspal. So I'm Laura Fry. I am also an interventional pulmonologist, and I'm at the University of Utah. I do a lot of bronchoscopy education and simulation. And I'm going to talk a little bit about some of the newer things in the simulation space, 3D models and VR. And obviously, we've already talked a little bit about how we use AI as well. The reason that 3D models, I think, are great for this type of education is that they provide realistic hands-on training as you saw with the model that Ash was showing, you can create those abnormalities that we encounter in the ICU. And so really you're getting that procedural practice on patients who have anatomic variants without risk to the actual patient. So we can customize those and make them fit various airway conditions. And then they're a lot more cost effective than the cadavers, the animal models, or some of the high fidelity simulation that we currently use in our bronchoscopy sim labs. Next slide. And so this is actually one of the 3D models that I think is a great example of what we can do for ICU simulation. So massive hemoptysis is one of the halo events that we encounter. And so how do we ensure that when our team faces this high acuity, low occurrence setting, that all members of the team are effectively trained? And I think we do this through simulation. So this was a 3D model that was printed by Melissa New and some of her colleagues, and it's designed to replicate the airway bleeding scenarios that we could see in the ICU or in the bronch suite. And you'll notice that it has blood in the bag on that bottom right photo, and then it has stopcocks that are connected to the simulator airways. So you can actually create the scenario where we are causing bleeding in the airway. You have to stabilize the patient's airway bleeding and then place a blocker. So again, I think it's a great demonstration of how we teach halo events in the ICU. And then the newer thing that we're going to see is sort of an increased use of virtual reality. And what is VR? I'm going to go through some definitions really quickly, and then we'll talk about the fact that this is ever changing. So VR, if you look at the Oxford English Dictionary definition, is computer generated simulation of a three-dimensional image or environment that we can interact with in a seemingly real or physical way using special equipment such as helmets with screens or gloves with sensors. Back in the 1990s, we had a very different definition. It was the use of computer technology to create the effect of an interactive 3D world in which we had like a spatial presence. Next slide. And then some more sort of definitions. So this is, I think, when people think about VR now, they think about the Oculus, they think about the head-mounted display. So these are displays that are worn on the head or as part of a helmet that give you either monocular or binocular vision. And they are able to sort of track 3D positions and put the user in a virtual environment. It's a wearable display, can be sort of projected with images so that you can see through them. There's a lot of different versions of this. So you have the Oculus, people have used Google Glass, things along that line. And then we have sort of the things to come. So we have augmented reality and mixed reality. And so augmented reality is when we take VR technology and we blend what the user sees and their real surroundings with something that's computer generated. So this is really that hybrid scenario where you can use VR or AR to augment what you're seeing. And then mixed reality is, again, emerging, but it's now emerging of the real world and the virtual world. So this is going to create a new environment where sort of these physical and digital objects are going to coexist. And so you see that sort of example in the photo where you've got this mixed reality with your true environment. Next slide. So child of the 80s, this is what I think of when we talk about VR. So we're talking about stereoscopes, right? So we've got our ViewMaster, we put our card in, and we're able to sort of interact with that environment. But what we have now is what you'll see on the next slide, which is the sort of Oculus or those head-mounted displays that allow us to really interact with the environment. And so obviously we use these for games at home, but we can also use these for simulation. Next slide. So now what is VR? It's going to continue to evolve. So you can see from the definitions from the 90s to what I told you from 2024, it's evolving. And when we look at a piece of literature that's talking about the outcomes of VR, know that that definition needs to be taken into consideration because it could be used differently now versus 5 years from now. And our new definition will likely make the current one obsolete in a few years. Next slide. So I think VR, if you look at how we're using it currently, it's used heavily in procedural fields, but we're seeing it more in nursing and other medical specialties. So they've shown, not surprisingly, that VR-based ACLS is going to improve learner performance. When GI fellows do VR-based endoscopy, they have better engagement and better outcomes. And then even VR-based pacer lead extraction has been simulated and improves the performance in cardiology trainees. So we're going to increasingly see VR for educational efficacy across all of our medical fields. Next slide. And so this is one of the studies that have looked at VR in bronchoscopy. And what they see is that when we use simulation in general, bronchoscopy simulation, VR or otherwise, is going to improve a few things. It's going to improve our process skills, our ability to perform the task. It's also going to improve our time-based skills. So we're going to achieve things more rapidly when we do it with simulation versus no instruction prior. Next slide. And then we also know that if we put somebody in a VR environment, they perform better when they're placed in another simulated environment. So this was a study by Anderson et al. And what they looked at was putting people in an immersive VR bronchoscopy simulation and seeing if they could train people to deal with the distractions that we frequently encounter when we're doing bronchoscopies. Could they maintain focus and the quality of the procedure? And so these were early trainees. They were in their first year of medical training. They had no prior bronchoscopy experience. They were given an instructional video about diagnostic bronchoscopy, and then put on a conventional simulator with the assistance of a proctor. And then afterwards, they either were put into a VR environment with training scenarios and distractions, or they were given 30 additional minutes on the bronchoscopy simulator without VR. Next slide. So you can see the simulator that they saw, they had a simulated environment, and then they were able to perform bronchoscopies in that simulated environment. And what they saw is that when they did the test, they did all participants after they were in that environment with distractions or the group without. And then the primary outcomes of those two groups were compared. They looked at completeness of the procedure and the time to perform the procedure. Next slide. And what they saw is that the group that practiced with distractions, the group that had the VR environment, had improved structured progress, improved procedural time, and they had improved diagnostic completeness. So using VR in bronchoscopy, again, is going to help with your task, those procedural skills, and your time-based skills. Next slide. Obviously, there are disadvantages to VR. It doesn't have the haptic feedback that we get when we are using a cadaver model, for example. Some individuals may get motion sickness. There could be technical and IT issues. And then obviously the startup cost is there. But once you have it, it's obviously going to have immense advantages because you can use it despite location and despite platform. Next slide. So I think we're going to see that VR is rapidly evolving. It's going to augment our medical education and that we can learn both cognitive and technical skills. How we deploy it is going to require some additional research, but I think as somebody who does a lot of simulation, VR has great opportunities because we can do it via avatars, so we can do it across countries, across communities. So I could, for example, be doing VR with my colleagues who are on this with me right now and our trainees. And so I think there's a lot of unique opportunities to come. Next slide. I think that's the end of it.
So this is fantastic. So I'm going to just I just think you guys did a phenomenal job explaining this, the lay of the land that was so packed with information and so many ideas, and my mind went all over the place. And I started thinking through, I had to step back a little bit. So let's say I have a hospital I'm working with, and they clearly need some help doing some basic bronchoscopy. what are the first things you tell them? Where they start? You know, they use disposables. Do they use you buy a bunch of equipment? Do you buy a bunch of mannequins? Like, where do you start with this whole construct, or do you send them somewhere else to get trained? Like, what is your thoughts so far? And start with you, Laura. We'll go backwards.
Yeah, I think it depends on what you have available, because obviously, like, if you're at an institution, so I started here at the University of Utah and had asked, like, I want to teach simulation. And I was told that I didn't have great resources. But then I looked at who my allies were in the region and partnered with those individuals. And so I actually was able to do simulation without a significant startup cost because of the people I was able to partner with. I think know your resources and know the limits to what you can purchase. Like, I would love if everybody had a high fidelity simulator that's $50,000, but that's just not the reality for most people, right? And so a disposable with a cheap mannequin might be the better option if you're not doing a lot of education with that 5-figure simulator.
Now, Ash, what are your thoughts on that?
Jasper, just to be clear on your question, and you're talking about procedural training for physicians who have kind of been in practice, haven't done much, and want to get back into bronchoscopy procedures in ICU and so forth, correct?
Yeah, all
Yeah.
of that. Like, I get that request a lot, right? I get a
Yeah,
lot of
yeah.
patients. What happens typically is a hospital says, you know what, we had a couple of situations recently where if we had just had bronchoscopy, we had a couple of this, where we had maybe had endobronchial ultrasound too, we could have had this patient taken care of here in this facility. And then where do you start that conversation? And so you start walking through, and walk me through that, where how you think those. I'm sure you get those calls as well.
Yeah, no, I think clearly there is a value in training nurse practitioners who are at bedside. If they had to go into in an intubated patient right there and identify there was a blood clot versus a mucus plug, and they could potentially help the situation. Or develop a communication channel that would open up a conversation where the patient belongs. I guess what you're asking is, how do we upskill existing human capital in a health system that may be resource constrained? And I would say, look at the volumes. If they're going to do probably 10 bronchoscopy or 30 bronchoscopy a year, there is no point getting a $200,000 cart with systems and put risk for damage of the scopes and so on. I think clearly it has been shown that if your number of procedures is less than 50, having a single-use scope is the right way to go. I would add to that, it is much easier to train somebody using a low fidelity model and do the just in time. And now with the technology and communication, you could add virtual reality at a very low cost, where you are the proctor and you're even actually able to do the case with them. So,
yeah,
that's great.
mentioning
Sabir, what are your thoughts? You come up with that quite a bit.
Yeah, I think you're right. At the early stage of curriculum, you know, the BSET, self-assessment, whatever tools you have available to you, and then you're going through the proficiency, the B-stats, and so on. And whether that is the Koken model or the TrueCore model, or a combination of things. And if you're lucky enough to have your simulator there, it's also about reproducibility, I think. So you need to have a structure in place. So if you are re-upskilling folks, you need to have them, you know, in the lab X times a week. The other interesting thing from my perspective is, from all our perspectives, can we do some of this learning at home? Can we transfer scopes connected to a smartphone or up to your video screen with relatively cheap models? That would be, you know, maybe something to measure. So I think there are a number of ways, but it needs to be structured and it needs to be reproducible.
if I may add,
Okay, I'm going to push back a little bit on that.
Yeah.
Go ahead, Ash.
Yeah, so I think the cost is very interesting, right? So in US, TrueCorp may cost $3,000. And then if you add, let's say you get a scope as a discount or free, But still, a low fidelity is not cheap. It's still a few $1,000s. And in countries where we are trying to import this skill set in ICUs where there's not a lot of pulmonologists, maybe they are intensivists, that could be an issue. It's something to think about. Yeah.
That's exactly.
No, that's
and we're just doing a study at the moment where we're 3D printed models in a shoebox. We're giving them to our ICU trainees, randomizing them to training twice a week in the hospital versus in their own time, but using a mastery learning. I mean, let's see. You know, that's very basic skills, navigation skills, but nevertheless, you know, it kind of opens the idea of broader learning in a home environment.
Yeah. Laura, you going to add something?
Yeah, I was just curious because Ash was mentioning the ability to proctor with VR. Obviously, I think in the surgical space, we're seeing more and more AI coaches and sort of AI proctoring of cases. Where do you think that will go in terms of this type of work for us? I know that you and Dr. Sethi wrote a paper about that already, but do you think we're going to see that increasingly with all of the tasks that we do in the bronch space?
I think we're probably going to go towards mixed reality in the sense that we're not just designing the reality for the procedure, but the actual environment where the procedure is done, and then integrate with actual learner in their own space. And I think that's probably where we need to go. What I do in my space, I have a lot of control, and I don't think people realize that it's become a second nature. My behavior has adapted. I have some intuitive sense of what's going to happen. That may not be the same. You change one cot in my room, and when I need a Fogarty balloon, I am probably in the wrong space. So the bad event can't be prevented. So I think we need to go to the learner's environment and bring that and adjust to that to coach them.
No, that's some really wise words, I think. You know, I was just, as you were talking, Laura, I was thinking about some studies that suggested that of recent surgical graduates, majority of the faculty would not recommend their graduates actually operate on them because of the number of case volumes, the technology advancements. Like, we're not going to be able to keep up with the demand for learner experience and volume and expertise. And I do think that AR or virtual reality or some augmented reality sort of solutions will be necessary in the future. Go back to Saveer's thing a little bit. So I'm just stepping back and reflecting on my last few weeks. Foreign body removal in the emergency room. The patient survived long enough for someone of us to see that patient. But sometimes there's an access issue with, you know, those types of skill sets. Like, do you envision, Saveer, like how do you approach those situations where you may not be the first one to see that person? That person needs has a life-threatening issue, and they are miles away from someone like yourself. How do you think through educating and how to advance those skills?
I mean, that's such an important point, right? Particularly in those emergency scenarios, the hemorrhage, the foreign body, the desaturation. I think it has to be multimodality because you have to empower the learner who's going to be in that position at one stage in their career through through knowledge, through training. It's about procedure as well, I think, because I think we've all been in that scenario. I remember once being about to take off, and my colleague is ringing me to say, we've got this situation, bleeding in the airway. We just went through what he had already trained on, and he was able to go through the steps and deal with that. So I think it is possible. You don't have to have seen something before. Nice if you can see videos in the courses that we do together with the training. And as I said before, the steps, I think, if you've got an algorithm that you can follow, then that is very powerful. And you just have to reinforce that with different modalities.
Yeah. I have a question for those of you in the group who do obviously this type of education. And you mentioned the algorithm and the steps. When you're working with learners, how important do you think it is to teach to the checklist and to ensure that they understand the algorithm and the steps?
Yeah, I mean, Ash?
So I think checklist is for both the runners and the proctors. I just want to make sure I add some context to that. What checklist does is it helps the runners not miss on the steps and kind of set a reminder to make it more of a fluid process mentally, that is cognitively and intuitively in their hand motion and so forth. Likewise, for the proctor, if they deviate from those checklists in the learning environment, I'm not saying you can do whichever way you want to do. It sends learner a confusing message, and they cannot pick up a skill at a basic level, a foundational level. And every learner can adapt, and they will adapt to their actual procedural environment. And I'm talking mainly in the context of procedure. And when they have to do that, they should have the freedom because they know their learning environment the best. So I think checklist is a process of providing scaffolding, which is critical. I don't get rigid about it. I think when people deviate, I ask them, what was your thought process? What was your rationale? And as long as they're logical, I think that needs to be encouraged. And as Suvir said, learner needs to be empowered. And that should probably be revisited when we are redesigning the checklist. So.
And I might absolutely 100%. And I might also add, the anesthesiologists and their airway framework is a very good model for that emergency situation. Their plan A, their plan B, their plan C. And, in things like airway hemorrhage or foreign body or a desaturation, that situation, that's a pretty good way, that a framework scaffold that we can use, so that that if you've tried this, the cold saline, the suction, the cold saline, it's not working, that you go to the next thing, whatever that might be, tranexamic acid or diluted adrenaline, and if that's not working, well, you've already called for help. What's the next thing? Are you going to put the ET tube down one side and just isolate the other side? So at least you've got those ideas, and I think that's a good way of teaching it and reinforcing it. Perhaps with videos, perhaps with simulations like the 3D models Laura was showing. Yeah.
No, this is fantastic. So I'm just going to kind of sort of summarize what we learned overall. It sounds like all of you agree that we basically have infinite new tools now that we need to potentially start looking at critically as newer ways to enhance the learner experience, to be more efficient and effective. That I think Ash, you brought up the point that the environment has to be considered. I think Laura, you planted the question that I think you knew the answer to, which is about checklists. Not just the milestones and the sort of the steps, but I think intrinsic to Ash, what you were getting at was a global fluidity, right? To trying to achieve that sort of picture and not confuse the learner. I think Suvir, you brought up several points about particularly related to achieving, like defining the task at hand and then trying to train to that task. Is that right? And then, and did I miss anything? Or is there one thing or so too that you want to leave the audience with?
I wanted to just mention that all of you we've talked about skills, and we've talked about competencies, and then we've talked about that human factors, immersive environment, and all of those elements need to be considered and taught to make the bronchoscopist effective in their space.
No, that's well said. Ash?
I would say be a happy learner and don't put the burden on the patient for your learning. There are plenty of tools that you can get better at. So
beautiful. And I will say one thing you did teach us also is that it doesn't necessarily mean spend all the money and get them all the resources. Find what you think you're going to use and use it often, right? I think you highlighted that as well. Laura, anything else you want to leave us with?
Yeah, and I will kind of piggyback off of that. It doesn't have to be the most expensive thing out there. I remember I was at a program that had printed off these like very cheap little lung models, and you could fit it in the pocket of your white coat. And fellows would pull it out of their pocket and stare at the lung model, and that was how they learned their anatomy. And these were cheap plastic models. So you don't have to buy the fancy toys and gadgets, although we love them. The cheap resources are also great learning tools.
That's great, and that does get me back to thinking about what Severe showed on the video, was the ability of industry to help refine the learning and bring additional tools for the learners as well. So for that single-use bronchoscope, identifying the airways, like to your point, Laura, these things are there, and use them, and it doesn't have to be to spend all this money, but they can be really good partners in this space as well. All right. Well, on the behalf of Society for Advanced Bronchoscopy, I cannot think of a better panel. You guys were fantastic. I learned so much tonight, and thanks to our sponsors, TSC LIFE. This webinar will be available to the broader audience. And so thanks all, and have a good night. And Severe, please get some sleep.
Thank you very much, everyone. It's a real pleasure, real honor. Thank you.
Thank you for your time.